I'm Katherine. I am a midwife by background and I'm currently working as a midwifery lecturer at the University of East Anglia and doing my PhD at City University of London, focused on the experiences of refugee women accessing maternity services. Maternal mortality is driven by a whole range of different factors, including three which are particularly intersecting that affect migrant women. So these are being of particular ethnic and racial background, being recently arrived in the UK, and living in a state of poverty. And we know that when a woman has just one of these factors, she's more likely to be at higher risk of mortality or morbidity. But when she has all three that are intersecting, that risk is multiplied. Not being able to speak English and not being provided with adequate interpretation services, a distrust of the system, a lack of awareness of how to access care. It could be that there's that mistrust is because of the midwife presenting as an authority figure and being part of a broader system of hostility. It could be that the woman simply can't afford to access care. So oftentimes a woman will have to get multiple buses or trains to be able to see the midwife. And when she's living on very limited funds, that is essentially a deterrent to access care. The woman may be deterred from accessing maternity services if she's worried that she's going to be charged for her maternity care, which presents itself as quite a significant barrier. We know that antenatal care is so important for women in protecting both their health and that of the baby. So anything that deters a woman from accessing care will make her more likely to suffer a morbidity or mortality. So women who experience multiple disadvantages accessing maternity care have multiple sort of services that are involved with them throughout their journey. So it might be sort of housing agencies, the Home Office, midwives, safeguarding midwives, social workers. It could be people working within the accommodation where she's living, so people working in hotels, a whole variety of agencies, charities, migrant support charities, citizens advice charities, volunteer doula groups, National Childbirth Trust support. There are a whole variety of people who are within that woman's experience of maternity, but those different parties often don't speak to each other. So there can be all sorts of different things going on, and a woman might assume that everybody's communicating, that there is this great big umbrella of care, but actually what's happening is there's all of this intervention going on, but in silos. Which can present sort of quite a disrupted picture of care for a woman. This is compounded even more if a woman faces detention or dispersal during her pregnancy. So we know that maternity care in detention centres is incredibly limited. We know that women who are dispersed during their pregnancy are likely to face significant disruption in terms of their antenatal care. So that might be to do with blood results, it might be to do with antenatal screening, scans, all of these things that are time sensitive throughout a pregnancy. If a woman is going from one healthcare provider to another, there isn't any sort of system of carrying all of that information from one place to the next. Charging for maternity care can be very stressful for women. So it can make women not want to access care, and that can even be an issue in future pregnancies. So a woman who's charged with a previous pregnancy may then be completely eligible for free maternity care in a subsequent pregnancy, but be afraid of accessing care because she's worried about the implications of any potential charges. And again, that doesn't necessarily just affect the individual woman. When, as a community, women know that there is this policy of charging, that fear can be passed from one person to the next. and it can become this shared anxiety about accessing maternity services for fear that you will be charged, that information will be shared with the Home Office that will then affect your claim and affect your ability to stay in the UK. The health implications for women of being charged during their maternity care are an increased level of stress, a lack of trust for their healthcare provider, which may mean they're not likely to attend for antenatal care, which then has a whole host of other implications. So antenatal care has been shown by various reports to be incredibly important across the world for women and their health outcomes, both for them and the baby. And if the woman feels that she doesn't want to access care because of these charges, that will have significant implications potentially for her health. This relates directly to charging because if a woman has higher levels of stress during her pregnancy, she has high levels of adrenaline and cortisol, which are pumping through her bloodstream and then pumping through the baby's bloodstream as well, that will affect fetal development. It means the baby's more likely to be small, it's more likely to be delivered premature, which then has huge implications for the baby's health. But more broadly, thinking about the woman's mental health, I mean, we know that suicide is one of the leading causes of maternal death in the UK. And again, it's something that is preventable with the correct input and the correct specialist support. For midwives who do come across charging, I think it will present them with quite a moral dilemma, because that midwife really wants to build up a rapport with the woman. She wants to develop a trusting relationship. And where there's this barrier to them creating a trusting relationship, in that the woman is fearful of being charged, the midwife doesn't want to bring up the charges because she wants the woman to continue coming to her appointments. It then puts the midwife in a difficult situation where she feels she has this obligation to the charges and the overseas visiting team, but she also has a strong duty of care for the woman. So when a midwife has this dilemma of needing to provide care for a vulnerable woman, but also has this issue of them being at risk of charging, it presents them with a really difficult situation morally. So I can think of an example recently where a woman, they really were trying really hard to get this woman to engage with her care. And when the woman presented to the antenatal clinic, as she presented, there was somebody there from the overseas visiting team. And the midwife essentially had to act as a barrier for this person to not go in there and speak to the woman. The woman was a victim of human trafficking, so wouldn't have been eligible for charging anyway. But it had taken them so long to foster that trusting relationship with the woman, to get her to present to the hospital for care, that to then have somebody come in there and be this this huge deterrent and this huge sort of blockage to the trusting relationship was really detrimental. And that midwife then had to be in this position where she's saying, you know, you can't come in, which puts her in a difficult situation professionally when she's working with somebody from the overseas visiting team, as well as that real moral dilemma of needing to provide safe, compassionate, holistic care for a woman to safeguard her and her baby, but also essentially act as border control in asking a woman to pay X amount of money for a service that should be free. Midwives, as part of the broader NHS system, are one of these sort of every contact counts professionals. So a midwife will see a woman multiple times during the pregnancy. She'll see her when she has her baby. The midwife will see a woman for sometimes a few days after she's had the baby in the hospital, and then will continue to visit the woman at home or see them in a postnatal clinic. So across the whole journey of a pregnancy and early parenthood, a midwife has multiple opportunities to ask women questions that will sort of lead on to disclosures of issues surrounding trafficking, modern day slavery, and destitution. And some of those aren't things that can be picked up from direct questions if a woman herself isn't aware that she is a victim. So a lot of it is to do with training and training on what those red flag signs are. Midwives have a unique role in caring for a woman, and there are things that she can do to mitigate those risks to women when they've been charged for their maternity care. And one of the main things a midwife can do is to advocate for the woman. And whether that means writing a letter of support that will indicate that the woman is destitute, that the woman isn't able to pay, that the woman is living in insecure accommodation, whatever it is, a midwife who's able to have the time and the space to really advocate for a woman, that's probably the best thing that she can do to mitigate against some of those worrying health impacts of charging.